this. All right, hello. Welcome to Sasko River Center's parent discussion series. Today, we're going to be discussing stress and evaluations, how they relate to sensory and other parts of evaluations with Dr. David Porrino and Deanna Lindberg, who will be presenting today. A couple housekeeping matters. First off, we will be recording this, and after this, today or tomorrow, I'll be sending this out to everybody via a YouTube link. We'll also make available to you the PDF of the slides that'll go with the email that goes out to you again by tomorrow. Regarding questions, Deanna and David would be okay with you chatting the question, and if it's appropriate, they'll answer the question at that time. Otherwise, they can answer the question towards the end of the session. They will be switching off with presenting. They will be, I guess Deanna will be presenting the slides, and then she'll be advancing them. Is there anything else? I guess that's it. This will be about an hour. We'll be recorded. My name is Mark Maydeek, and I introduce now Deanna and David, who will be presenting on stress and evaluations.
Thank you, Mark. Deanna, do you want to start the share?
Mark.
Sorry about that.
Yeah, we've been at this 2 years, but there's always some new tech issue that gets in the way. It's all good. Hi, everyone. I'm Dr. David Porrino. I'm a neuropsychologist, and I'm our director of testing. Today we'll be talking about, as Mark said, stress and how it intersects with questions of whether or not it's appropriate to do evaluation and what specifically might be worth looking into. Deanna, do you want to elaborate and introduce yourself as well?
I'm Deanna Lindberg. I'm an occupational therapist, and I'm the clinical director of occupational therapy at Sasko River Center. I'm here to talk about when it might be more relevant to start with intervention, or also I work with David on multidisciplinary testing to determine sometimes when it's more relevant to have a comprehensive evaluation in order to be able to support our students and children through stress.
All right. So let's talk a little more about our presentation today. So, in keeping up the overall theme with these discussions, which perhaps some of you have seen some of the earlier discussions, is specifically related to stress. That's a term that has many meanings in our society. So we're going to talk about what is clinically significant stress on more of a technical level, as well as terminology for things like how to treat stress, and other particular matters. We're also going to talk about different types of evaluations in young children all the way through adolescence and even into young adulthood. Where this could be useful when stress is perhaps part of the challenge, and yet we sometimes need to figure out what is driving the stress, because that can really help determine what the child needs. But we'll also talk about what kinds of therapies are common for kids who are struggling with stress, because as Deanna noted at in the prior slide, it's often, sometimes it makes sense if we know that there's stress and we feel like that is the primary issue, it might make sense to get treatment started, whether it be with OT. And so we'll be talking a little bit about therapies, as well as helping yourself kind of come up with a decision tree for whether it makes sense to get started with the actual services and treatments versus trying to take a deeper dive and figure out what are some of the underlying factors involved. Okay, so what is stress? Well, an organization in DC called the National Institute of Health, or NIH, defines this, I think, pretty succinctly in saying that, stress is the body's response to physical, mental, or emotional pressure. So yes, we think of stress as we often think of it as anxiety, and certainly it can get to that point. But what's happening is stress is a physiological response where different, as this quote goes on to describe, there are changes in the body in things like heart rate, blood pressure, blood sugar, especially over time, a hormone called cortisol is increased. And that's where we start to see there's short-term stress, and then there's longer term stress, where we can see more significant implications in terms of both mental health and physical health.
I wanted to call to terms some terms that are commonly used, especially in children around stress. One, so David already talked a little bit about anxiety, and stress can contribute to anxiety if it's prevalent over time, and even depression from sustained exposure to stress. But when we talk about children, a word that's commonly used is the word dysregulation. So I have a really dysregulated child, which basically means that a child's having a really hard time and is behaviorally acting up. So we're seeing in their behaviors, they're crying a lot more, they're a lot more impulsive, they're not acting the way that their peers are acting. So we often call that dysregulated. So we might use that throughout the presentation. So I wanted to bring that to your attention. And another common word or phrase that we use in thinking about stress, especially here at Tasco River in occupational therapy, is sensory sensitivities. Sensitivities in our sensory systems have a really interesting correlation to stress, as the more that we are stressed, we tend to be more sensitive to the stimulation around us. So you might notice that when you're feeling more stressed, you are able to hear maybe the air conditioning click on more readily, or you're more irritated by somebody chewing around you. So that those play a role in kind of how you might eventually bring in an OT. Also, sensory sensitivities can contribute to higher levels of stress. So it's a little bit of which came first, the chicken or the egg, but this is why we wanted to bring it up as something important related to stress and testing, because if you are a child or yourself, if you are more elevated to sensory stimuli that other people are not, that can be stressful in an environment that other people aren't feeling stressed in. So these are some words that we might use throughout our presentation. So before we kind of dived into the topic of why evaluate, we wanted to talk a little bit about what does stress look like. So I think in order to understand what stress looks like is we have to understand these two really important systems in our body. So we have the sympathetic system and the parasympathetic part of our nervous system. The sympathetic part of our nervous system is the fight or flight mode. That is our stress aspect of our nervous system. So we also often hear the term fight, flight, or freeze. So this comes from evolutionarily, you needed to experience stress in order to be able to run away from dangerous stimuli, or to be able to hunt and have that flight aspect where you're able to run really fast and kind of catch the deer or whatever you were kind of going after. So that small amount of stress was important, and it would activate the sympathetic nervous system, which engages that kind of fight reaction. So that's where you can see some aggression. And in children, that can look like aggression. It can look like having a tantrum. It can look like defiance or pushing back. You can see a flight response. So a flight response could be kind of leaving an area, or maybe running out of the classroom, or complete refusal to participate. And a freeze, we don't see this one as often, but that's where you can sometimes see completely shut down behavior, where they're in certain cases, sometimes people will pass out or just completely not engage. So that fight, flight, or freeze response. And for everybody, a small amount is important and helps us perform it at our best. If you think about like Olympic athletes, you want to be your heart rate a little bit elevated in order to be ready to compete and do well. It's when it's too elevated for too long of time that it's harder. Then our parasympathetic is what we want to be able to engage in order to combat that stress. So in our everyday life, our sympathetic nervous system's engaged, but we're able to kind of combat it, which is with our parasympathetic, which is that rest and digest system. So these are some kind of funny pictures of somebody that's engaging in their sympathetic and then their parasympathetic nervous system. The difficulty in using your parasympathetic or activating your parasympathetic nervous system once you're already in that fight or flight state, that's when we start to have questions about, should we be testing, or should we look into some interventions in order to support a child in their everyday life?
So then the practical question, well, what stresses kids out? I mean, Deanna mentioned that there's an evolutionary function to these different aspects of our peripheral nervous system. That sympathetic is this back thousands of years ago when a saber-toothed tiger was coming at you, you needed that strength to be able to fight or flight. And then you need that parasympathetic activation because that sort of deviation from what we call homeostasis in our body is dangerous if it's happening constantly all the time, right? Today's day, slightly different demand on kids. Because there was a longer period of time where from an evolutionary standpoint, where we needed this fight or flight response, we still see that for stressors that are actually much more benign, where that fight or flight response is actually not helpful, but that's just what our bodies are programmed to do. So not that it's always not useful, but in a lot of situations in everyday life, there's kind of an answer for that does not require that level of stress response. So what are some of the things that commonly stress kids out? Well, school or academics, reading, writing, math, homework, just the sheer volume of getting things done. Kids can get a lot of homework today in today's days. So certainly in any child, these are pretty common stressors. And then more socially related stressors as well. So related to play. So whether that's getting along with young kids, getting along with other kids on the playground, being accepted by peers, or in kind of more performance-based play or sports or things like that. And an important question to ask, however, as Deanna alluded to, with sort of this chicken or the egg question, is, okay, well, maybe stress is making these activities inherently challenging for the child. Maybe because they're having some difficulties with this type of emotion regulation, how could they focus on their reading or their homework or get along with peers without second guessing themselves? But sometimes we also need to ask the question of what if it's the other way around? What if, just to throw out, Johnny is having trouble reading and he is not acquiring the principles of literacy development, and that is making him really stressed and really nervous and making him avoid reading further, just as an example. Or socially, maybe Johnny is having a hard time picking up on social cues and inherently has difficulties reading between the lines, and that is stressing him out and making him avoid social situations as well. So these are some of the questions that we need to ask to figure out, do we need to take a deeper dive and figure this out a little bit better?
Absolutely. And as David mentioned, kind of these first two areas with school and academics and play, they might have those more underlying causes, which is a little bit of an inclination of maybe we want to take a deeper dive and to test, or it could just be an average level of stress for these types of things. Now, the other areas that I'm going to talk about, which are kind of new situations and rare unforeseen events, these are typically it's very normal to have stress from these, and you might not have that background of needing to take a deep dive. It could be more of an intervention-based approach in order to work on the stress that's caused from new situation and rare unforeseen events. So new situations, there's lots of children that don't like going to a new camp or starting a new school. It's normal to have a normal level of stress when starting these new things. It puts us at our best. The other reasons that there could be challenges here is because children might not be able to have the flexibility in order to kind of adjust to those types of changes, or they like things that are more in line with what's predictable because they know that they'll have the same sensory experience and they're not going to be necessarily overwhelmed. Rare unforeseen events is also something that children often can experience stress around. Sometimes you'll have a child that's afraid of thunderstorms, or that they maybe heard about a hurricane and now they're afraid that that's going to happen. Now they can develop significant fears that are impacting their daily life, but it's more of something that would be treated on an intervention-based approach versus we need a huge evaluation to rule out academic or other performance-based challenges that are raising their anxiety level or stress level.
Okay, so then let's take a little bit of a dive into, some of the, towards the bottom of the last slide, what Deanna was talking about situations where we don't necessarily need that deep dive. And we have a feeling, okay, this is primarily stress, chronic stress, so something that perhaps has morphed into something like anxiety or depression, or, related symptoms. And, what are some of the first steps towards treating that? So, I think what we conventionally think of is our talk therapies, which for those of you who don't have personal experience with either yourself or your child, these are depicted often through the media of ways where that's not actually how it looks sometimes. But individual therapy is a common way to treat anxiety, in particular, and stress that has a lot of research support, and particularly for anxiety, a type called cognitive behavioral therapy. And so that's where you're helping kids who might be making errors in their thinking of perhaps them seeming like they did something horribly wrong, and really it's more their anxiety talking, and you help them talk to their anxiety or exhibit behaviors that or learn behaviors that help them reduce stress, just as an example. There's group therapy. So an example is, when I get a referral that really seems like the primary issue is social anxiety, and it's not a problem with, say, social skills or social relatedness or something like that, then sometimes group therapy is also very, very effective, in that even if the child relates to their peers in a typical manner, having a little bit more of a playbook of appropriate social skills for when they get anxious can actually be a really effective augmentative treatment, just as an example. So there's lots of group therapies. Family therapy is another one where some of the stressors, if there's a lot going on at home, that can help the parents, help continue those therapeutic skills and provide continuity. Even in these individual therapy approaches, the therapy is only happening about 1 hour a week in a traditional therapy. So, what about the other 167 hours of the week, right? So these are also, that's also an approach, as well as parent coaching, and for very young children who don't yet have the level of self-awareness and metacognition to have a great grasp on their emotions. This can be a great way for parents to model ways of thinking and talking and expressing feelings that is just much more developmentally appropriate for a child who just does not have that command of therapeutic and emotional language. And then also, we at SASCO, we have people who prescribe medication, psychiatrists, nurse practitioner, and this can be, medication management can also be very effective, and kind of a gold standard approach is with SSRIs, selective serotonin reuptake inhibitors, that can really help reduce the symptoms of anxiety or depression. Are they helping the causes in the person's life? Not necessarily, right? That's where some of the skills and developing coping skills is really important. But at the same time, these things can very often have a genetic, have some genetic links and genetic causes. And so this can really help with symptom management.
Then there's also occupational therapy, which is a type of individual therapy that can help to support the reduction of stress. A lot of people don't necessarily know this about OT, but occupational therapy actually had its roots in mental health, and that's where it was originally developed. And OT's, the definition is, what are your daily occupations and what's impacting your ability to do those? So looking at day-to-day things and how can they support access, which can in turn support mental health and or the reduction of stress. So in order to be able to do that, there's several ways that occupational therapists can be a supportive role in reducing stress. So one that's common and that we do at Sasko River is sensory integration. So for a child that might be in a very stressed state, there are exercises and the ways you can stimulate the nervous system in order to support that parasympathetic system. It's kind of like using your body as medicine, and it can be a really effective approach, especially for younger children. Although those strategies can be used up through adulthood. It's about learning about your body and engaging in your body in a way to activate relaxation. Other ways that OT can help to reduce stress is to work on what are the areas that are causing stress. So if there are sensory sensitivities, as I spoke about a little bit earlier, that can be causing stress. And there you can actually reduce the type of sensory sensitivities through neuroplasticity and working on that skill in OT, as well as sometimes there might be motor aspects that are harder for certain children that are raising their stress levels. Working on those can help to overall reduce stress. A few other areas that OTs work on is one area is called reflex integration. So there's certain primitive reflexes that are associated with stress that can be integrated if they're present. That would have to be evaluated. OTs also, and as well as psychotherapists, are trained in something called the zones of regulation and self-regulation strategies. And I would say they take different types of approach because our background or OT's background is in what's impacting your daily occupations to be able to participate in that, and sensory-based strategies as part of the zones of regulation, where psychotherapists might take a different level of approach with kind of what is the best match for your child. And similarly to what Dr. Porrino spoke about was some parent coaching on sensory strategies for the family to support regulation, as well as how can you do break down daily activities to help it be the just right challenge and not overly stressful for a child, which can kind of support the family's reduction in stress.
Okay, so we've talked about a little bit about how do we treat stress when stress seems to be, really the primary issue. And I have certainly had consultations with families where, they think that they need an evaluation, that evaluation makes sense. And when I hear the concerns, it really seems like this child needs some sort of therapy, and that there aren't the typical markers of what we call a neurodevelopmental disorder, where it wouldn't be necessary to spend tons of time and energy and resources on trying to disentangle that. And I make a more quick referral for therapeutic services in that particular case. But sometimes we find ourselves asking these questions of, well, why? What is underneath this stress? And when it seems to be, first of all, I always tell families that when they're on the fence about whether or not an evaluation is needed, I always say, well, how is your son or daughter doing at school? How are they meeting their academic benchmarks? Are the teachers raising concerns? Are they stressed at home and saying, I don't understand this, I don't understand that? Are you noticing that they're not picking up on things? When it seems that it's very closely related to affecting them at school or in their learning in particular, that's one where I really think in evaluation. I'll talk a little bit about the different types of evaluations that I or someone else at our center would do. But when it seems like that's the case, that's a different, it's a little bit of a horse of a different color in that scenario. And also when we think about sustained focus, my child constantly resists anything with sustained mental effort. Anything, my child can play with Legos all day. And if it's reinforcing and interesting to him or her, then it's no problem. But the second we have to do anything sustained, it's just immediately a chore. That sometimes clues me in. Okay, well, maybe there's a problem with the child's ability to sustain attention or be organized or related skills. And then social situations. My child is having a really hard time making friends. My child is not interested as much as I would expect in their peers. My child is missing the mark socially. So these are questions where I would recommend either we'll call it neuropsychological evaluation or neuropsych, and those are the evaluations that I specialize in, or a psychoeducational evaluation, which we say psychoed for short, which is done typically in the outpatient setting by a clinical psychologist. Well, why do that? Well, we want to rule out what we call a neurodevelopmental disorder. And so these are disorders that, often have a genetic origin, but the core feature is that this is something that's present usually in utero, or if it's due to some kind of acquired cause like a brain injury. The neurodevelopmental aspect is that this is happening early in the course of brain development. And these are the disorders that tend to affect kids a lot at school in particular. And that's where we need to take a deeper dive because, yes, you might be treating the stress, but if you're not treating the cause of the stress, you're still going to see stress. And also the child's academic skills are going to be impacted. So some of these are, very commonly attention deficit hyperactivity disorder or ADHD. High functioning autism spectrum disorder is a common one where we're wondering if that could be going on if there are social implications. In the past, often this was referred to as Asperger's. Over the past 8 years or so, 8 or 9 years, everything on the autism spectrum is just called autism now. And specific learning disorders or learning disabilities. So most commonly, the one that we know the most about is dyslexia, foundational reading deficits, but also problems with writing or math development. And then in more severe cases where we see lots of areas affected, like speech, motor skills, higher level language, and academics. Sometimes we want to make sure there isn't kind of more of a global impact. So that's what a global developmental delay or intellectual disability looks at. So what are some of the differences, similarities? So there's a lot of overlap here. In fact, I supervise psychologists here who do psychoed evaluations. A lot of the tests are actually the same instruments. There are just some differences in the background of the evaluator and sometimes the clinical focus of the assessment that really make the difference between a neuropsych and a psychoed evaluation, particularly as it pertains to children, adolescents. So they basically, these are individually administered tests. We're not doing small groups or anything like that. And we are responding to a particular referral question. Does my child have autism? Is my child on the autism spectrum? My child has had a brain injury. What are the cognitive implications of this? Those are just a few examples of what a referral question is. Or perhaps another provider is making that referral question, be it the pediatrician, psychiatrist, an educator, or something like that. So as I said, we use a lot of the same instruments, and a neuropsych evaluation is performed by a clinical neuropsychologist. We all have generally, we have the same degree in terms of we have a doctoral degree in clinical psychology, but neuropsychologists, we specialize along the way, tailor our coursework, and then we have a specialized pre-doctoral internship and a 2-year fellowship, and where generally we're getting very focused testing experience, often in hospital settings and with kids with medical conditions. And the idea is that we develop specific experience with brain behavior relationships. So a lot of our thinking behind the scenes is, okay, well, we know that these brain areas and these brain networks serve these functions. So I'm going to look at that area. We use our understanding of neuroanatomy, to really drive our test batteries and our case conceptualization. But at the same time, we might overlap in the same cases. We might even can't come to the same conclusions. We think about the case differently because our training is different. So yes, some of my referrals, for example, are children who have complex medical histories, like some of those examples on the slide. But also I see plenty of kids with learning disabilities, dyslexia, ADHD, autism, where there can be an overlap. It's often the experience of the evaluator. So a psychoed evaluation is performed by a more general clinical psychologist. This is really appropriate for a lot of referral questions, especially in high functioning kids. And really it depends on the experience of the evaluator. There are some clinical psychologists who I work with who have amazing expertise in dyslexia, and I would rather have, if it were my child, I would rather have them to do the evaluation than a neuropsychologist who's worked exclusively in hospital settings. So it depends a little bit on the background, and there really is a lot in common. Kind of a way to think of it is that there are some procedures, say, that a general surgeon could do, And there are some procedures that a specialist can do, and sometimes there might be an overlap, and there are cases when one might be more advantageous than the other.
So I'm going to talk a little bit about what OTs would test in order to determine what area to intervene on. And this is really kind of focused on what I had already spoke about. So what were the areas that we're intervening on in order to be able to evaluate those to determine that they exist. One is that we can assess a child's general arousal level and what are their ability to self-regulate. Another area we can assess is what are sensory sensitivities that they may be presenting with in order to be able to work on those areas, as I talked about that neuroplasticity, to make things less sensitive to them. There are many different motor skill assessments that we do, and we almost always will do a motor skill based assessment just as a rule in or a rule out, or kind of what is a child's kind of approach and even ability to regulate to do that type of test. And the last type of test that we will do that can be related to stress is assessing primitive reflexes. So if there's, like I mentioned, if there's certain primitive reflexes that are present, they can be associated with stress. So we will evaluate for those.
Okay, so let's talk a little bit about a little more the nuts and bolts. What does an evaluation actually look like on not quite the granular level, but just to understand, tangibly, these things can be kind of abstract when you haven't had experience with them. So, I'll give a little rundown of how this works within our center. So, we have 3 intake coordinators here at SASCO who do a wonderful job of fielding that call of, my child is interested in evaluation, and just making sure that that is indeed what the line that should be followed, and making sure that it isn't some kind of mix-up where, perhaps a provider recommended an evaluation, but something else was implied or misunderstood. So step 1, just making sure that someone contacts our center and that it's triaged appropriately. If it does seem like say a neuropsych or psychoed evaluation is indicated, an intake session is assigned to that clinician. When intake is for us, we do an hour, and we get a really comprehensive history of the presenting problem, because that often sheds light on what some of the primary challenges are. For example, if something presented early in development, it's more likely to be a neurodevelopmental disorder. But if something has a more sudden onset, it's more likely to be more anxiety, depression, more of a psychiatric type cause as opposed to a neurodevelopmental cause. But we also just generally get a sense of, okay, what are we doing here? What are the primary concerns? What are your goals for this evaluation? How can we be of help to you? And we all get on the same page about all those important factors before moving on. Then sort of the next phase is the actual testing phase, where the child comes in. Totally depends on the referral question, the reason for referral, but a comprehensive evaluation where we're evaluating really all higher level brain functions, and we're evaluating academics and social emotional functioning. Generally, that's about 7 to 9 total in-office hours. And this is customized around the child and clinician and everything. So sometimes 2 sessions, sometimes 3 sessions, really depends on the scenario, but it is a good chunk of time that the child is actually in our office. And the collateral information is, we are asking parent specific questions, giving parents symptom rating scales, with parents' consent. We're reaching out to teachers and educators to get a sense of how this shows up at school, because that's all really important information, determining, what are some of the primary factors here that are going on that are driving a lot of the symptoms. After we've had time to review all that information and come to our conclusions, we have a feedback session with the parents, where we really discuss, as I said, what are the primary issues, what are the most important takeaways from this evaluation. We discuss any diagnoses that might be pertinent, and then perhaps most importantly, what should we do about this? What are steps? What are some actionable steps we can take to address these concerns that have really been quantified by the evaluation, where we've actually put data compared to the child's peers to get a sense of how how primary, as I said, those concerns are. And then we provide a written report, which which parents always have to look at. And also in a lot of cases, it makes sense for the school to have it as well with the parents' permission, because often we also do evaluations that are funded by school districts, and the schools say we really need to understand this child better, and so we can help be an advocate for the child, but also just help the school kind of get a handle on him or her so that they can connect at school and really help get their progress going. And then for older children, really depends on the age. Often over 10 is just a very rough rule of thumb, but it really does depend on the child and the presenting issue. We'll have a developmentally appropriate feedback session with the child as well. Something in the ballpark of 20 minutes is usually all that kids really want to hear. We don't want to bore them to death, but at the same time, we keep this very strengths-based and also layer in where some of the challenges are. And often the child feels very validated, feeling like I always felt this way before, or say, wow, I didn't know that. But at the same time, they're often pleasantly surprised by their strengths, and it can be really empowering for the child.
I'll just comment that for interventions specific, so occupational therapy or speech therapy, this process is a little bit shorter than would be for the psychoed or a neuropsych process. So the amount of time in clinic tends to be shorter. The turnaround between the feedback session and the ability to start supports is just a little bit shorter.
Okay. Sorry.
No.
So we also do multidisciplinary evaluations, probably not surprising, we're a multidisciplinary center. And so what a typical multidisciplinary evaluation entails is either a neuropsych and a psychoed, plus an OT, speech language, or occasionally a psychiatric evaluation. Most commonly it's OT and speech and/or speech language. And Deanna and I in particular do quite a few of these. And the idea is we are putting our heads together to create a blueprint for the child. That's the goal with any psychoed or neuropsych evaluation, is let's create a blueprint for the child so that we can really help them move forward in all of these key areas. But we really are able to use our background and our different types of expertise. We find these most useful when there are multiple areas of developmental concerns or delays. So, there is a cognitive concern or an academic concern. There's also a motor concern or sensory concern or speech and language concerns.
I would just add that often from psychoed or neuropsych evals is they might make the recommendation to get a OT or speech and language evaluation, which is completely valid and a great trajectory. The advantage of multidisciplinary evaluations is you have the evaluators from all their areas collaborating in order to be able to kind of determine the need altogether versus kind of do this, then this, and having different providers kind of give their own expertise from their perspective. You're having that joint unified approach.
Okay, so going into a little bit more of the details of a psychoed or neuropsych evaluation. So I mentioned, we're looking at, in a comprehensive evaluation, we're looking at higher level brain function. So IQ, I'll talk a little bit more about that. Some language, attention, executive functioning, learning and memory skills, academics, visual, spatial, and motor abilities, as well as social emotional skills. And I mentioned, the importance of data here is that, there are some tests where things are subjective and qualitative, but what is often really, really helpful when parents come in with concerns for a child who hasn't been evaluated before is say, I hear your concerns. Let's get some metrics on them and let's see relative to their peers, how much your child might be struggling in some areas or how strong your child is in some areas. And so really the best way to do that is through administering tests that have robust samples and are based on a normal distribution, so that we can determine, well, I see where those challenges are, but actually isn't quite as much of an issue as we thought it was because your child is actually within the average range. Or perhaps a child seems to be compensating and some skills are more of a challenge than we might have expected. But the way to really get a sense of it is to truly compare them to, say, if the child's 8.5, other 8.5-year-olds. Okay, so a little bit on IQ. IQ is a composite of IQ as this deterministic number. There's several things that go into the IQ. And so if a child, just like the way averages work, if the child has some really strong skills, but also some much lower skills, that an average would not necessarily be helpful because it doesn't get a sense, it doesn't capture that variability, right? So what's really important is to get a sense of where the child's strengths and challenges are. So there are a number of IQ tests with subtle differences. The most common factor structures of IQ tests generally divide verbal as well as nonverbal skills. So verbal skills are kind of our higher level knowledge, our vocabulary, our ability to connect different words and concepts, our command of facts and those related higher level language skills, but also our nonverbal skills. It's a little bit more what we associate with our right brain, which is being able to think more fluidly, solve puzzles, pick up on patterns, think spatially, and being able to understand part-whole relationships. So sort of those top two domains are what we more conventionally think of as intelligence. And then, in the IQ literature, the jury is sort of out on whether supportive skills should really be considered as IQ. And, the most common IQ test considers these as part of the IQ, but these areas are working memory and processing speed. So working memory is not so much me telling you a story and then 20 minutes later having you tell me that back. That's more episodic memory that I'll talk about. Working memory is just the ability to really hold a chunk of information in mind for a temporary period of time. Usually you have to mentally manipulate that information. So it's the reason why phone numbers, way back in the day, we had to remember them, are generally around 7 digits. That's usually enough where we can hold it in mind, we can run upstairs, and we can dial it into the phone. So that's kind of more short-term working memory. And processing speed is what it sounds like, just the mechanical aspects of information processing, scanning information, how fast does that happen, in the different areas in our brain. So attention and impulse control. So, we look at this just based on, often just based on qualitative observations, relative to the number of kids we test, how long can the child stay on task, how's their response to tedious versus more novel, interesting tasks. And then there's these things called continuous performance tests, and there are many of them. You can read about them in the literature. They're kind of everywhere. But the idea is that there's sort of a go, no-go component where you're assessing how does the child respond over a period of time, and do they respond impulsively. So Deanna, I know you're the one who's controlling the slides, so I'm going to have you vary up the amount of time that you press the next slide button just for show. But the way that these things are usually presented are, you'll see something one at a time, sometimes it's letters, sometimes something else. These instructions have all been altered, and this is not a real test. What you would do is say, tap your hand on your desk or your lap as quickly as you can when you see a letter, but do not tap when the letter is R. So that is the go, no-go component. So Deanna, if you wouldn't mind. Okay, so that was kind of an interesting exercise, right? Doesn't get much more boring than that. Just looking at some single stimulus on a screen for an inordinate amount of time, and then also kind of controlling that impulse is something that can be really difficult for kids who have attention and executive functioning problems. So we hear about executive functioning a lot in literature, and really what this is an umbrella term, but goal-directed behaviors that are associated with the frontal lobe of our brain, and so our ability to, whether that's inhibit a behavior that's automatic, plan our approach to a task. So be able in our mind to think of, oh, okay, this is a complex task. Here's the first way I'm going to attack it, second way, and third way. Initiate, so get started on something. So they're different skills. They're different. They often map on different parts within the front part of our brain, but they're important in a lot of higher level school and things like that. Memory, so learning and memory, episodic memory, that's more the middle of our brains versus the front of our brains, like I talked about working memory. So that would be something like me telling you a really long story, have you tell it back to me, and then 20 minutes later, hey, do you remember that story that we talked about before? Academics. This is one where having some background in working with schools is obviously very important. So we're looking at reading, writing, and math. That's everything from really basic fundamental skills, like word reading and decoding. Our reading, for example, are foundational skills that are implicated in dyslexia. If you don't have those, sometimes kids with dyslexia can comprehend what they read, but the amount of effort, because the lower level skills have not been mastered, has to be extreme. So we start at that foundational skill level to see if there's any breakdowns, and we go all the way up through the higher level skills as they become developmentally appropriate for kids. And lastly, the social emotional. This is done through a number of ways. Anyone in this group who's had their child evaluated, usually you've completed some sort of symptom rating scale where kind of like what we talked about with the normal distribution, the normal curve, we get a sense of, okay, here are the concerns I have, say, about anxiety. For using our example, an 8.5-year-old child. To what level are those concerns normal? Are they within the normal range? Are they a standard deviation above what we consider normal? Are they 2 standard deviations above what we consider normal? And in that particular case, that helps us determine, that helps us really sort of triage issues and, what are primary. Direct testing, there are specific tests, say that we do play-based measures that we do for autism. There are different types of direct tests that we do to try to get a sense of more qualitative and theme-based approaches to things like anxiety and depression. And then also the observations we make in the room. And then in certain situations, classroom observations are helpful to get a sense of if something looks really different at school, or there are some significant implications at school for social emotional factors. Either the evaluator will go and do an observation, or someone else from our center will go in and do one.
And what we would look at from an occupational therapy perspective is our sensory systems. So clicking and speaking is always a little bit of a challenge, but we actually have 7 to 8 sensory systems. So as part of a sensory processing evaluation, we look at all of them. So touch, hearing, smell, taste, and sight are the ones that you've probably heard of before. The 2 other ones that are really important, especially for regulation of our parasympathetic nervous system, is your vestibular system and your proprioceptive system. So your vestibular system is located in your inner ear. It's what gives you your sense of balance. It's related to attention as well. So that can be related to stress, as if there's an attentional factor. And your proprioceptive system is in your muscles and joints. It's what gives you body awareness. It's also a really strong regulator it helps to release serotonin, which is why we feel really good after we exercise and things like that. So what an OT evaluation would do is look at some of the background in these 7 sensory systems, specifically from 3 different areas. So there's 3 areas of sensory processing. One is sensory modulation, which when we talked about sensory sensitivities at the beginning of this presentation, that would be under sensory modulation, but it would be your initial response to sensory input. So do you perceive something too much, or do you perceive something too little? If you perceive auditory input too much, that can be very stressful in multisensory or classroom environments. If you perceive something too little, you might not be getting the message that you need to be getting. Then there's sensory discrimination, and that is the what of something. So if I put my hand in my pocket, I can feel the difference between a quarter and a nickel to grab the quarter for the vending machine versus the nickel. These are things that we do automatically throughout the day that support our motor skills. And if they're more cognitive, now we have to put more effort into something, which can raise our stress level and make it more difficult to be able to execute those higher level tasks that we call sensory motor skills. And this might be where you may have heard of OT historically as well. So this is where fine motor skills play a role, visual motor skills, postural skills, which is kind of strength and core strength, and something called praxis. So praxis is the ability to think of an idea, plan and execute it, and then adjust your plan if you're not initially successful. This can be an area of stress because if you can't adjust your plan really well, you can try the same activity the same way and have, we all know typically how that will come out is you'll have the same response, which can be stressful if you're trying to do, play on the playground and you're trying to climb up something and you put your feet in the same holes and you're still not able to be successful. It can be frustrating as it's not as easy for you as somebody else. This is a key chart for how OTs are looking at stress is our arousal chart. So arousal kind of is actually a fancy word for stress. Is when we're in a high arousal state, that's another word for being stressed. Low arousal is more is when you're lethargic or kind of not activated. Most people are able to kind of maintain this green zone of arousal. That's where we want people to be able to maintain, although research shows that we are becoming a more stressed society, that we all experience stressors during the day. So we kind of get a little elevated, but are able to use that parasympathetic nervous system to be able to regulate. Are there days that cumulatively you experience too many stressors that now a simple request that maybe yesterday didn't bother you, like a question like what's for dinner, now is deemed as stressful and causing a fight or flight response? Yes, because there's a cumulative aspect to it. But that might not be on the regular. So part of what the occupational therapy evaluation would be looking at is what is increasing that arousal level from a sensory processing perspective, and how can we work on that so it's not kind of raising that arousal level to the same degree, as well as what strategies can we use in order to help bring a child or a person back down into that green or optimal zone of arousal. As I mentioned, the last area that OTs would be evaluating is that motor skills, or that top part of the pyramid. So this can be fine motor skills, so that's things like buttoning, manipulating beads, opening your backpack. We use fine motor skills all throughout the day. So if those are more challenging, it can certainly contribute to stress. A big one is handwriting. If it is harder for you to execute the motor task, sometimes you can have all the great ideas and you know what you want to write, but the motor execution is actually harder. Or maybe you even write it and then it's not legible. So then it becomes stressful as what is for other people to know what you were trying to execute. Manual dexterity can fall under fine motor skills. Bilateral coordination are things that allow us to do sports like throw and catch a ball, do jumping jacks, etc. There's tests for core strength norms as well as primitive reflexes. So the next part of our presentation is really going to be when is it important to test, and what is that decision-making tree? Because there are certainly times that it is very beneficial to test, and then there's other times that it might be more beneficial to take an intervention or start with therapy first and then test later, or it might not even be necessary. So a couple of reasons not to test would be that, first of all, that the problems are primarily anxiety driven. So when I spoke about the different areas that causes stress in children, one of the areas I talked about was specific new situations or specific fears. Those are very anxiety based and can be worked on with a child therapist or working through parent coaching strategies. There's not the question of, is there a lot more going on underneath the surface? So that might be a reason to go for just working with a provider that's providing a level of support. Another reason to not test would be that there's not a lot going on at school, and that's a question that when I'm kind of asking families if they're going to take the next step to testing, are they seeing the impact at school? Are they seeing inattention? Are they seeing behavioral dysregulation at school? Are they seeing academic concerns? If the answer is yes there, then that's when we might want to know why, versus if it's only happening in the home environment. And the school is saying that they're doing really well across those domains, there might be more of a kind of a, it's okay to take an intervention specific approach first, and kind of see what resolves. And then if there's more left, you might want to take the step to testing. Developmental constraints. So testing really little children isn't always beneficial unless there's a question such as autism or kind of global developmental delays. But even then, sometimes kind of getting started and then doing more comprehensive testing in the future. But starting with early intervention is always really important for those types of children, because when they're younger, their nervous system is just developing so much quicker. So providing intervention at that age can really support that. Time, sometimes we might not test because a child's not able to attend for that amount of time yet. So there's been situations that we want to help a child be more regulated, whether they're going to a psychiatrist and getting some medication, or if they're working with occupational therapy, or developing the skills to be able to participate in the tests in a better manner. There also might be the factor of that they've already had a lot of testing, so they don't need to commit more time to that. And the final one is cost. So sometimes if there's kind of a question mark and we're not really seeing that it's impacting at school yet, taking an avenue that is doesn't have the same financial commitment and seeing kind of what results can you get from just intervention, because sometimes it will resolve itself with intervention, versus needing to do a full psychoed or neuropsych battery to then get the intervention to see the same results.
And if I can just add for a sec, Deanna, just one question that Mark alerted me was posed in the chat is how many hours is a psychoed eval? So really depends on the age of the child, and some evaluations are kind of more targeted and focused at a specific question, but often we do recommend a comprehensive evaluation if the child hasn't been evaluated in the past. So that total is about 7 to 9 in-office hours for the child. So in older kids, for example, you might be able to just get it done in about 7 hours and have them come a couple of times for 3.5 hours. In a younger child where there are some attentional challenges, might be taking more breaks, might need to break things up. It's pretty fluid. In a preschool age child, so say 5-ish, 4.5, 5-ish, we're looking more at like 6 total hours, spreading them out over 3 days. And then also adding a little bit to kind of like that cost benefit analysis, as clinicians who are, helping first families. I mean, the child is the focus, but the people who come to us first are our parents, and we want to, we ourselves are doing those cost benefit analyses in terms of what is going to have the most meaningful impact. And sometimes when I consult with parents, and to me it sounds like, as Deanna commented, there's not much impact on school, and my suspicion for a neurodevelopmental disorder is low. Sometimes I'll make the suggestion of, look, I don't know if this is worth this kind of expense, because we're going to end up with the same recommendations at the end of this long and sometimes enjoyable process. Some kids like coming in and getting the attention, but they're less long and costly process as we're getting right now. So let's try these interventions, and you might see a lot of the other areas kind of dissipate a little more when the treatment does what we intended to do.
So I'm going to talk about a client that I have seen. Everything has been changed, so there's no identifying factors, but we'll call this client Carly. So she actually had an intake with one of our psychologists, and her parents were thinking that it would be best for her to be evaluated with a psychoed evaluation. She was demonstrating some school avoidance or some difficulties transitioning to school. However, once she was in the school classroom, they were identifying no concerns. Her academics were strong. Her ability to relate with peers was strong. She showed a lot of sensitivity to clothing and was only really willing to wear 4 to 5 outfits, which was limiting to the family. The one thing that they did notice at school was a little bit of difficulty sitting still. They saw that at home as well during meal times, but it wasn't impacting her academic performance, impulsivity, or attention, or things like that. As Dr. Porrino mentioned, when in that intake meeting, sometimes the clinician or the psychologist might say, okay, I don't know if you need to go testing right away, which was what happened. Instead, they made the recommendation to, why don't you pursue an occupational therapy evaluation and then do some parent coaching / play therapy, and we can reevaluate if there's psychoed testing is needed kind of at a later date, more closer to the age of 7, which can allow some more differentiated tests to be able to be done. So the outcome of this case was the child had about 9 months of OT 1 time a week and about 5 months of play therapy with some parent coaching. And they made a lot of progress in clothing tolerance, their vestibular processing to be able to sit still and improve regulation. And so then they decreased the frequency of OT and play therapy to just every other week, or during periods of transition. So sometimes during periods of transition, such as when you start school, or maybe even when you end school, or when the demands are increased, their regulation became a little bit, they had a harder time or showed some dysregulated behaviors. They'd have a small boost of sessions, but then were able to back off. And so they actually didn't end up needing the psychoeducational testing, as there really wasn't a pervasive underlying diagnosis going on. Obviously, it could have gone another way. There could have been intervention, and while with intervention, improvements would occur, sometimes kind of they improve to a certain level, and that's when we kind of want to make the question of maybe further testing is indicated at this time. I've seen very similar cases to what's outlined in front of you. Decide to get psychoed testing at a later date, and maybe there be an ADHD factor. And like Dr. Porrino said, the interventions are very similar depending on how they're presenting, and they still sought benefit from that, but understanding them as a child with ADHD and kind of conclusively stating that later on with the full psychoeducational testing, they were able to just kind of set the trajectory up for the next several years.
Okay, so what are some of the reasons then to get an evaluation where perhaps something would be missing in that child's, say, blueprint? So here are some practical reasons, right? So what we frame this as at the beginning is what is often most common, which is this is sort of this top middle of, we're concerned about a neurodevelopmental disorder that without this evaluation, we can't really identify what's going on. Is it a learning disability? Is it an attention problem? How does the person's actual profile shake out? And from there, we can determine what they need at school, what they need at home, what they need in a clinic setting. And that's really important. There are some other reasons as well. And these are perhaps less pressing reasons nonetheless, where you'll see some benefit. So understanding the profile can be really empowering. I talked a little bit about how, especially with older kids and adolescents, how they can get a lot of benefit out of understanding what they do well, what they struggle with, and what does that mean? And helping them feel validated for maybe some things that they suspected their whole lives, but no one's really put into words for them. I've talked a little bit more about, how in more of the neuropsych world, how are some medical conditions that have, say, a neurological impact affecting the person's cognitive functioning, their academic functioning, just going through the rest of these, what are some of the what are the types of help that the child needs. Sometimes we'll reevaluate kids, in special education under, I believe it's IDEA. Kids need to be reevaluated every 3 years when they are on an individualized education program. And sometimes we'll evaluate kids and then see them again after a few years. And it's great. It's great to catch up. And I've done this before, and it's really nice to see how kids have grown physically, but I'm often impressed that, wow, this child is as tall as me now. But more importantly, emotionally, and how have they benefited from the interventions that they've had? So say that the child has dyslexia and I've diagnosed them with dyslexia. And that's changed the course of what they get at school. Has that increased intervention improved their foundational reading skills, their phonological awareness skills, stuff like that? And then lastly, in getting more of this information, and in the cases with older kids who can understand this in a more developmentally appropriate way, helping them learn to advocate for themselves and be able to really articulate what they need, and especially when it comes to going to college and where there aren't IEPs, for example, in college, and it really is up to the child to self-identify. This type of evaluation can be helpful in that aspect as well. So I will share my own study. This was a neuropsych eval that I did. This also could have been a psychoed eval with the right clinician. So once again, like Deanna's case, this has been entirely redacted, as well as information actually being changed. So we'll call this young man Max, and so Max was a sixth grader, and he was. Parents and teachers really described him as being forgetful, having problems with organization, rushing through work. But in avoiding sustained work, reading really stuck out. And he, especially when it was just large volumes of reading were really challenging for him. And so, in meeting with the parents for the intake, what we really got on the same page was, okay, is stress affecting his school performance and detracting from his attention? Or is it that the learning and the focus that seems to be contributing to the stress? So when I really looked at this evaluation and compared his performance to peers in all of these different areas of his cognitive and academic skills, I actually found that he had an attention problem as well as a language-based learning disability and a kind of a mild dyslexia, and that it seemed like a lot of the anxiety in speaking with him, he wasn't really anxious during the summer. It wasn't, weekends weren't such a big deal for him. Socially, he was doing great. And it really seemed like a lot of this was him just feeling like he was behind in school for some of these reasons. So we were able to educate his team at school and help people around him understand him better, as well as make some adjustments to the amount of intervention he was getting, the type of intervention he was getting at school, and some of those related programming facets.
And then we're going to share a case that David and I did together that turned into a multidisciplinary case. So this 10-year-old girl, Kate, she came in with a lot of signs of stress, where she was, especially in social situations, she was avoidant, didn't want to participate, or having kind of big behaviors or emotional meltdowns, especially after those events, or was easily triggered during while she was socializing with others. She demonstrated attentional concerns, difficulty sitting still, actually really limited attention, but had such a high need for movement. She also had sensory processing concerns, that she would kind of chew on objects that weren't food-based, but more for the chewing aspect versus ingesting anything. She just needed to be chewing back on pencils, things like that. So David met with the family, and there was the determination to do the neuropsych evaluation, which had the cognitive, academic, and emotional factors, paired with an OT sensory screening, which just targeted the sensory processing factors that I discussed and didn't have the motor component, since there wasn't any motor concerns, as well as speech and language screening. Again, there wasn't the whole language-based evaluation, really just for the autism markers done by the ADOS. So the results came out that there were sensory modulation concerns. So she had an under-responsive vestibular system, which accounted for some of the high need for movement. And some of those sensory seeking behaviors, and that she needed more proprioceptive based input, which was where some of the chewing behaviors were coming from. And those also led into some of the other factors that David will discuss.
Yeah, and sometimes these things are interrelated, but on testing, I definitely saw some problems modulating attention and being able to sustain attention for long periods of time particularly on mundane tasks, as well as some problems with hyperactivity and suppressing impulses and impulse control. We also saw some challenges with her ability to communicate, her social communication skills. So not just in terms of her language and her conversation skills, but also in things like eye contact and understanding body language, and a lack of what we call social emotional reciprocity, which is kind of the back and forth of social interactions. So making social bids towards others, in being able to have like a conversation that has multiple steps where the other person in the dialogue's input is welcomed and the person is picking up on cues that they want to contribute. We saw some challenges with those types of things, as well as specific markers for autism, like repetitive behaviors. So we did find, as a multidisciplinary team, that this child met criteria for high functioning autism, as well as ADHD and anxiety. Anxiety is very common in autism and a very characteristic comorbidity in autism. And so, the point here, so it's not just an academic exercise, obviously. In some ways, the diagnosis is not what's most important to convey, it's the blueprint. And how do we help this child adjust better and function better and be happier? And so we came up with a plan of sensory-based OT that Deanna programmed, and pragmatic language. So pragmatics are more the social implications of language. So we have a speech and language pathologist who was able to talk about that aspect of the blueprint. And then as well as, medication management for some of the anxiety symptoms. And we also discussed, we haven't outlined here, but there are also more of a traditional therapy-based approach with someone who was appropriate for this type of client to really help with developing coping skills for anxiety. Okay, so just some final thoughts here. So just a review, right? The decision of whether or not to pursue one of these evaluations, one of these comprehensive evaluations. It's most helpful for ruling out a neurodevelopmental disorder. As I've said, ADHD, learning disability, something in that arena that might actually be causing the stress, or perhaps not causing, but maybe they're happening in parallel. Often there's just a higher rate of comorbidity of anxiety and depression and stress among kids with neurodevelopmental disorders than of the general population. Another thing to consider, though, is that these evaluations, we really do help people use data to make decisions, and because we help figure out what your child needs. So the approach of just looking at possible interventions and picking those interventions, that might help, right? Something might, if you throw something at the wall, it might stick. At the same time, using data can save a lot of wrong turns. The wrong turns can lead to a lot of time and money. And yes, there are costs associated with these evaluations, of course. At the same time, if we really need some data to base our decision making, it can save money in the long run. And so some examples, I said, academic interventions. If you can help the school understand what the child needs, that can be really helpful in saving time to help the child get to where they're going. Medication for say attention problems, anxiety. And then evidence-based therapies. When we can identify what some of those primary concerns are, we can really save a lot of time, and try to really be of help to the child and family.
Okay. And now we're going to open it up for any questions.
Yes, and one as well, I did get through the chat. Someone asked what are the costs of a psychoed eval, and identified a particular area of concern and age. So towards that, it does depend on what the nature of the concern is, the age of the child. For example, we have different fees for, say, a preschooler who can't handle as much testing versus a school age children. So what happens in that first point of contact is when you discuss with the intake coordinator the most primary concerns, the intake coordinator at our center gets a better sense of, okay, what type of evaluation approach will the clinician probably recommend, and from there can quote a range. So each case is really handled individually.
Not sure if there's any more questions, but while we wait for any possible ones, I want to thank you both, Deanna and David. That was very, very good. Appreciate that. All the information is very useful for me and the kids, of course. Guess we can hang out here for a minute, but I'll just reiterate that this will be available to you, PDF and recording of the presentation shortly, sometime by tomorrow. And if you have any follow-up questions, you can respond to the email that I send out, and I'll make sure that gets to Deanna and or David, depending on who's appropriate, or you have their email addresses at the end of the presentation as well. And if there's nothing else, I guess, have a great day. Actually, there's another question from chat. Any thoughts about Endeavor, a prescription program for use with autism child? Not sure what that means, but maybe you do, David.
I haven't heard of that specific program. Deanna, have you?
I'm not.
Yeah, I mean, there's so many programs these days, and I don't know if this is a medication management programs. The authors of video game needs prescription. Interesting. So
we got presented on that, didn't we, or something? Wasn't there last year? I think
Ethan, right? Ethan and Dan talked about
Daniel, they did a presentation on that. Yeah, I think so.
Yeah, I think that was a slightly different topic pertaining to video games. Yeah, I mean, I think it really, I would have to see if they consult the literature on this. The thing about, if it's about, say, brain games, those have some modest effect sizes for specific skills. Often the barrier to those is just time, and if a child is finding it tedious, then the level of benefit is going to sort of be dependent. However, also for kids on the spectrum, there is a pretty good body of literature about the use of, say, video modeling of different skills, as well as being able to team those up with a child's specific interests. So say a child is very interested in trains, and they're having trouble in their daily life reading facial expressions. It's a very, very common issue in autism. There are studies that show that if you expose a child to different facial expressions on trains, just a hypothetical example, that they actually improve their ability to read facial expressions. So there's a lot of good research in the UK about that. So it depends a little bit on what the use of video games is, and I'm sorry I can't speak to a specific program, but I think that the importance is just that the program has been peer reviewed and literature reviewed in a comprehensive manner.
There's a couple more questions, but before anyone answers those, I'm going to stop the recording for now. Yeah, stop the recording.